Okay. So welcome everyone. My name is Dr. Anthony Rivas, and today our presentation is going to be the use of supervision in theory and practice. Some logistical things. Please, if you can, make sure that you are muted, and that way it is not distracting anybody as we are as I am talking. Okay, I'm put on the closed captioning for anyone. Make sure that you can see it. If you're having problems with the closed captioning, please let me know. So let's hop in and we'll get started. So I think everybody is here for use of supervision in theory and practice. My name is Dr. Anthony Rivas. I'm a licensed marriage and family therapist in the state of Colorado. I'm also a licensed addiction counselor in the state of Colorado. I'm a master addiction counselor in the U.S. Department of Transportation substance abuse professional. Currently, I am an assistant professor in the master's program in counseling at Sacramento State University. I also act as the rehabilitation counseling specialization coordinator. And I have been a clinical supervisor in the state of Colorado for both licensed addiction counselors. And currently I am working on my AAMFT approved clinical supervisor for the MFT credential for licensure for our credential to supervise in Colorado as well. So welcome. Thank you, everyone. During this presentation, if you have questions, feel free to use the chat, or you can save them for the end of our 50 minutes together. I'm pretty easygoing when it comes to that. So whichever is most comfortable for you. So our presentation outcomes, a few outcomes I have for us today are, I'm going to set a timer, forgot to do that. It's always good to do. Is for everyone on here to at least have somewhat of an understanding of the characteristics of effective systemic clinical supervision. Also to understand the need and methods of assessing current counselor level of skill, as well as methods for documentation of needs, plans for improvement and needed areas, and understand the methods for giving supervisees appropriate, timely, evaluative, and supportive feedback regarding areas of strength, as well as areas of growth. I normally do this over 3 days, 8 hours per day. So 1 hour is going to be a primer. So don't walk away from this feeling that, there's much that you only have a small grasp. This is quite a large topic. And one of the things is just starting this conversation. And I just want you to think, you don't have to answer out loud, but I just want you to think of how many of you had clinical supervisors that articulated and communicated to you what their theory of supervision is and how they were going to conduct supervision with you. I also want you to think during this process of how many of you understand and know your theory of supervision, what that looks like. And if you are able to communicate that to your supervisees. And that really starts this conversation of what supervision is and is not. So first and foremost, what is clinical supervision? Bernard and Goodyear wrote the text. It is Fundamentals of Clinical Supervision. And they are pretty much Hi, everybody. We're gonna please make sure you mute as you enter the room. Bernard and Goodyear have set the stage, and they are the experts in clinical supervision. And they've defined clinical supervision is provided by a senior member of the profession to a junior member of the profession of the same profession. Sometimes a very closely related profession, but generally the same profession. It's evaluative, it extends over time, and has the purpose of enhancing professional growth and functioning, as well as monitoring the professional services offered to clients by the trainee or the supervisee. It also included in supervision is gatekeeping. And we'll talk a little more about gatekeeping as we go on. Supervision also entails monitoring our supervisees as well as ourselves for fitness to practice, impairment, and it guides practice. Clinical supervision guides practice. Oftentimes when I meet with new supervisors or supervisor trainees, the guiding practice part is an area of a little concern for them, because we often feel that individuals, and coming from a counseling standpoint, the individuals are able to make determinations for themselves. One of the things as a clinical supervisor is you are directly responsible for what your supervisee does. And so guiding clinical practice entails knowing exactly what is going on within their clinical settings. And so, as I said before, that's where that evaluation comes from. And it is inherently hierarchical. There is a hierarchy that has to be maintained for good boundaries and also to ensure best clinical practices. Within supervision falls both administrative and clinical. The clinical we talked about just a second ago. Administrative is more of the policies, procedures, the promotion, demotion, suspension in an agency of a supervisee. Oftentimes in small agencies or in a private practice setting, you may have multiple roles and you may be both administrative and clinical. And so it is important when you are supervising that you either communicate and delineate what those roles are, because they do serve two different functions. Administrative, there is some carryover where administrative is looking at documentation and case notes for completion and for timeliness. The clinical supervisor is looking for completion, timeliness, and to ensure the veracity of the clinical notes and the languaging that is occurring in it. Does that make sense? So it is important to understand both of those roles. Another aspect of clinical supervision is liability. And liability occurs in two forms: vicarious and direct liability. I joke with my students when I'm teaching clinical supervision that state boards assume that clinical supervisors are omniscient and omnipresent in their supervisee's life. And so you know all and you see all. The fact that we're human beings really negates that fact. Most of us are not omniscient or omnipresent. And so one of the things that we want to ensure as clinical supervisors is that we are working with our supervisees to be accurate and honest with us in all their case presentations and their clinical work. So direct liability as a clinical supervisor entails what is happening in session, what we are guiding, what we are doing, what we are our actions. And that could be malpractice, that could be telling supervisees to do something unethical, allowing supervisees to do something illegal or unethical. That would be a direct liability. Vicarious liability is when our supervisees are doing things that would be considered malpractice, unethical, illegal, and yet we are unaware of it. And we can still be held liable by most boards. Today, I was teaching clinical supervision for the state of Colorado for CAT classes, and the question came up, with vicarious liability, and it's if your supervisee is filling out case notes and misconstruing hours. Instead of seeing a client for 50 clinical minutes or 55 clinical minutes, they're only seeing them for 30 and they're billing for 30. That's vicarious liability. That would constitute insurance fraud. Any questions on that? I know I'm kind of talking a little fast. I'm looking at my clock and it's, I'm talking faster than the clock's moving. Okay.
No questions in the chat so far, but if anyone has questions, please feel free to put it in the chat and I can help monitor.
I will be pretty honest about.
Okay. Okay. So some relevant factors influencing supervision. And these are things as a supervisor that we do need to be aware of. And those are the contextual and cultural issues, state regulatory issues, ethical issues, legal issues, performance and evaluative issues, documentation issues, methods of observation, administrative and clinical supervision issues. And we'll talk a little bit more about those. So contextual and cultural issues, meeting your supervisee where they are, understanding their cultural capital and what they're bringing to the supervision relationship. Supervision is an intimate relationship, much like counseling is. Supervision can walk up to the line of but it does not cross over the line of counseling. And so sometimes our supervisees will bring up and into their supervision sessions things that are coming up in their life. And our sole role with that is to determine if it's impacting our supervisee and how it's affecting the clinical relationship between them and their client. It's understanding how the greater society impacts our supervisee and impacts the clinical relationship. As supervisors, our role is to protect not only the client, but the field, and also the supervisee, and also being selfish, protecting yourself, because your license in almost every state is tied directly to what your supervisee is doing. And so paying attention to those contextual pieces that are occurring within your supervisee, understanding how the world's impacting them. Another component is being an expert. And yes, I use that term an expert because the idea is if you're supervising somebody, you have more experience and more knowledge than they do. And so hence that puts you in the position of being a supervisor. So being an expert in your state's regulatory issues, being an expert in your ethical components related to your professional organizations, whether it's ACA, whether it's NADAC, whether it's AMFT, whether it's NASW, whether it's ASCA, understanding those ethical components and communicating that to our supervisees, not just hoping that they go and join those organizations or hoping they go and read those ethical codes. It's educating them and walking them through it, as well as your state statutes. And that falls under legal issues, right? Understanding HIPAA. I work also with substance use disorders. And so 42 CFR is an additional concern when we're working with substance use disorders. And so that is a component of HIPAA. Many of my students, that the first time I bring it up, or the time I bring it up to them, is often the first time that they hear it, understand it, or have ever had it addressed. I think there is a question in the chat.
So Dr. Rivas, the question is, you mentioned supervisee impairment. Sometimes there is impairment and other times there is problems of professional competence. Any suggestions for determining if students have skill difficulties versus skill deficits?
Okay, so skill difficulties versus skill deficits. So impairment, we're looking at, are they psychologically, emotionally are impaired, or are they using substances that are affecting their clinical judgment? Are they have boundary violations, i.e. dating clients? All of those would fall under impairment. So if a student is using, or a supervisee is using drugs or alcohol to the point where it is problematic, California, Colorado, many other states, marijuana is legal. Are they using marijuana prior to going into session? Are they using other drugs? That would fall under impairment. Are they having a psychological, are they being triggered in session? And so the session becomes about them. That would be, we're assessing, we're still using that clinical mind to assess clinically where our supervisee is, albeit we're not providing therapy, we're still assessing them clinically. That's how we determine whether it's skills or not. Because if we're seeing a skill deficit, i.e. they're not able to join with a family and family therapy. They're not able to identify what a client's really saying. That's going to look different than clinically. So if they're presenting where they are unable to paraphrase, let's go to micro skills, are unable to paraphrase, that's a skill deficit. versus if a client is bringing up a painful or traumatic experience and our supervisee starts to cry uncontrollably. That would be more impairment. I'm not sure if that answered the question. Please let me know if it did. But that would be the two ways to discern it.
Yes, thank you.
You're welcome. And that falls under performance and evaluation issues. So with supervisees, much like any other job in the world, there's an evaluation process. And I'm going to share with you an evaluation that I have. It's IDM, and that's it's a developmental model. But we want to be immediate and timely with our performance and our evaluation. KCAREP requires for students 1 hour a week, and states vary for licensure. I like to over supervise. That's just me because my license is online. I'm going to be honest. And so I want to make sure that's the selfish part. And the other part is I want to be there for my supervisee. And so I would prefer to over supervise to under supervise. And as supervisors, don't let things slide. There is a difference between being mean and direct. And we need to be direct and have immediacy, much like we do in our sessions with clients. We have to immediately identify what's going on and address it, both positive and negative. It cannot be all negative. When our supervisees are doing good, highlight that. When they're doing something or an area of growth, we want to highlight that as well. I see a question pop up in the chat. Okay, nope. Documentation issues. Document. Just like working with clients, we need to document every interaction we have with the supervisee. And the reason we want to document that is A, it's best practices, and B, that we can go back and as we go through time with our supervisee, we can identify areas of growth and areas that we need to readdress. Some things that do, and I know this just anecdotally from my past, one of the things that neophyte counselors have concerns with are documentation and getting documents in on time. And one of our roles that kind of crosses over with an administrative component is ensuring that documents are, case notes are done on time, treatment plans, disclosure statements, all of those components are being done. Most states require direct or indirect observation. Most accrediting bodies require indirect or direct observation. And so that's another relevant factor of supervision. And I think I already spoke about administrative and supervision. Other areas to pay attention to are the 6 foundational areas of supervision. And that goes into having a theory of supervision and understanding your role within the therapeutic relationship and how your theory, whether it's an integrative model, a humanistic model, a psychoanalytic model, a systemic model, how that fits into your relationship with your supervisee or your intern. Other areas of concern are personal assessments for readiness for supervisory roles. Many folks who work in agencies, you know this, as soon as you are licensed and you are eligible, and even the states do this, you may be thrown into a supervision role. And one of the things I would say for this, and it does come from a place of privilege, is to advocate for yourself if you feel unequipped at your developmental stage to supervise. Because if you feel you're unequipped and you don't have the skill set, it's going to be a really hard experience for you. And so there are multiple ways to get additional training, such as this we're doing today, which is just scratching the surface. AMFT offers a credential. NCCAP, or NBCC, sorry, offers the ACS, Approved Clinical Supervisor. As does NADAC, offers an approved clinical supervisor. I believe NASW does as well. And that gives you more experience and more education in the roles of supervision, which helps prepare you to become a supervisor. And we've already talked about most of these other things. So I'm going to kind of peel back for a quick second and just, as a supervisor, there are multiple moving parts. And I was just telling a class I had the other day, when you're a supervisor, if you have a caseload, let's give you a small caseload, and you have 10 clients, and you take on 3 supervisees, and they each have 10 clients, you didn't just take on 3 supervisees, you took on 30 clients from your supervisees because you are going to directly supervise and direct their clinical practice. So for you as a supervisor, you need to be prepared for that additional workload that is coming to you. And so I do encourage that advocacy piece of advocating for yourself if you have the capacity, the bandwidth, or even the readiness for it. Any questions or comments on so far? I know it's just
Nothing in the chat, no hands up yet.
okay, thank you. So I want you to think about, and you can put it in the chat, or you can comment on it. What was the best supervisor you had? What was the worst supervisor you had? Don't name them, please don't name them. But think about the qualities that made them the best. Think about the qualities that made them the worst. Now I want you to think to yourself, of those qualities, which ones do you embody, both good and bad? Right? We're human beings. We have both positive and negative attributes. Do you have more of the attributes that align with what you think your best supervisor was, or what you think the negative supervisor was? Because that is what you're bringing to the relationship. We don't want to water the garden of negative attributes. We want to water the garden of positive attributes. But we want to be aware of what negative attributes. I've noticed something myself teaching on Zoom, that I have a tendency to get a furrowed brow, and I have a tendency to look into the camera like it's a microscope. So if you notice during this, I've been trying to look over the camera to get rid of that. But that's something to be aware of, is what am I bringing as a supervisor to the group? Because over Zoom, it can be misconstrued that my furrowed brow indicates dismay or anything negative. And so it is being aware of our own personal self. So who are you as a supervisor? What is your philosophy? How do you supervise? What worked best with you? What was effective with you? How do you effectively communicate? Do you have a particular philosophical underpinning that drives your therapeutic orientation, right? If you're a humanist, client-centered, you prefer CBT or behaviorist, how does that translate into your theory of supervision? What do you think supervision should look like, right? What do you think are the fundamental issues? What is your job as a supervisor? Is it just to sign off checkboxes, or is it to really guide clinical practice? Hint, hint, it's to guide clinical practice and grow a new generation of clinicians, competent, reflective, ethical, and legal practitioners. That is our role. What regulatory issues? What's required in your state? I have moved from Colorado to California. Two different states, some similarities, some differences. So understanding what's required in every state you're operating in. If you're in a different country, what are the requirements for certification and licensure there? And so understanding that as you are working with your supervisee. What's required in your state? Does your state require supervisors to have training or a particular educational component before they can supervise? And the best and worst. And I think that question really lit up the chat, because, one of the things, and I'm just going to grab a few, worst, completely left me alone and did not guide. Best, a lot of encouragement. I was on my way. Balance between counselor, teacher, and consultant. Worst, no feedback at all, except you're making sure paperwork was in order. Those are the things that really impacted us as supervisees. And one of the things I want you to take away from this is how not to negatively impact your supervisees, and to be that one. And I'm going to go back to that one. I really liked that, the balance of teacher, counselor, educator, right? making sure that we are training competent clinicians. Any questions or? So some competencies for you as an expert supervisor. You need to be an expert, and I know I'm wielding that word around quite heavily, but as supervision is hierarchical and you are a more senior expert in your field, you need to be skilled at screening, assessment, diagnostic assessments, understanding how to diagnose not only clinical mental health concerns, but substance use disorders. And I'm going to put that little out there that, as we've seen in currently in the pandemic and isolation, we've seen a 36% uptick in substance use disorders. And something I've noticed is oftentimes substance use is treated as a secondary concern. Co-occurring disorders are very real. And so I would encourage all of you all out there to ensure that your skill set includes that diagnostics of substance use disorder. You need to be an expert in counseling and case management, treatment planning, consultation, crisis intervention, client, family, community education, and referral report writing and record keeping. Now, I know some of you are probably thinking to yourself, oh my gosh, I can't ever be, how do I know all these things? And education, never stop learning. And so within this context, the reason I say you have to be an expert is because not only are you supervising, you're educating your supervisees, your interns, your trainees. They are looking to you to guide them in all of these areas. Now, if you're not an MFT, family therapy may not be your area of expertise. That doesn't mean you have to go back to school to get another degree. It means that you are also expert enough to say, this is outside of my realm of knowledge. Let me find you the answer or refer you to somebody who is. And so I want to expand that definition of expertise into knowing our own areas and our limitations and when we need to refer our supervisees out. Yes, we can refer our supervisees out to another supervisor who is more competent in areas. And that is an ethical obligation, is when we cannot meet our supervisees' needs, that we do refer them out. Any questions or comments?
No hands up and nothing in the chat just yet.
All right. So some questions for you to ask yourself, being heavy-handed again on this one. And I'm going to put in the chat, or I'm going to ask the moderator if they could put a couple of files into the chat for me. Tip 52 from SAMHSA. It is a clinical supervision, and it is an abbreviated version of Bernard Goodyear's book, and it has theoretical models for supervision. It also has assessments to work with supervisees, and it has how to structure supervision. It even has interview questions to ask your supervisee. So questions as current supervisors or future supervisors, I want you to ask yourself, same question I asked you at the beginning. What is my theory, philosophy of supervision? How do I approach supervision? How do I structure it? What do I see it as? Do I see it? And one of the comments for the worst supervisor was just a checkoff. I'm here to make sure the hours are correct, right? Do you structure supervision as for time for working on case conceptualization, education, and growth of the supervisee? Or do you look at it as just a momentary blip in time out of your day? What are the cultural, idiosyncratic life experiences and family of origin issues that influence my supervision? We all came from a family of origin. We all have information in our background that guides our view in life. It even guides our clinical practice, sometimes more so than others. And one of the things we need to do is also work through that with our supervisees. We need to attend to our own countertransference as well as our supervisees with our clients, and we need to understand that. Other things, how do you manage power, values, core beliefs? How do you work with your supervisee when maybe some of their areas are diametrically opposed to yours? So I'll stop there for a second. So I get this question a lot. That a person really loves solution focused. The supervisor is solution focused, but the supervisee is really interested in narrative therapy. What do we do? Do we force solution focus on them, or do we help them explore narrative therapy? What do you think?
Explore.
Yeah, we explore. If our theoretical foundation is narrative and they really love solution focus, we're going to help them explore that for them. And so one of the things as a supervisor is you're going to constantly be learning about maybe theories of theoretical orientations that aren't your favorites, that don't resonate with you, but they resonate with your supervisee. And that gives them a much more rich and robust supervision experience because you're working with them with theories that resonate with them. Does that make sense? And so we have to be able to manage those and not impart. One of my best supervisors that I had really taught me that component. He sat me down and he asked me what was my theoretical orientation and how much I wanted to learn about different ones. And then he also explained to me at the agency what the primary mode was used, and it was an agency, so we used CBT, solution focused. And but he balanced that with me. He worked with me exploring more so what really resonated with me, and then what we did in the agency as evidence-based practices. And so, I would encourage you to look at that. How do you manage those components within your own supervision session? And how do you manage understanding and knowing the legal, ethical, professional, contextual issues that are occurring in the supervision session? How many of you all feel very comfortable, think about it, knowing all of the regulations for your state, right? Most of us, we have a clinician's understanding of the mental health statutes, and the rest of the statutes are written in legalese because it's written by lawmakers and lawyers. And so, it is a lot to absorb. And so I would encourage you to not only invest in that component for your own understanding, but it also models for our supervisees that in this field, we're constantly learning, growing, and looking at ourselves and looking at how we interact with our field. Does that make sense? Some other questions, as I alluded to it a minute ago, is how do you manage transference, countertransference in the supervisor-supervisee relationship? What do you do? How do you address areas of clinical skill development? That was that question that came up before. And professional experience, my supervisees. Trust but verify, right? Our supervisees come out of graduate programs and we're going to trust that they were trained. But much like any educational setting and much like any other human being, we only take from our education and our experiences what we want to take from it. And so one of the things is walking with your supervisee through case conceptualizations, walking them through skills. And I really like the developmental model because it starts off very much, and I'm going to just make it like bullet pointed. When the supervisees first enter in the supervision relationship, they are neophytes, novice, and they know absolutely nothing. So it's very educational, it's very guided, and all the way up to when you're signing off on their licensure hours, that they are now becoming a peer. And so there is a level of growth. We wouldn't treat a neophyte counselor as if they've been in the field for 25 years. Unfortunately, that happens more often than not when you have a supervisor that maybe is overworked, maybe burnt out, and where you entered the field, and I'm sure most of you could probably have a story like that, where you had a supervisor that just checked in with you, did the hallway check-in, and was like, you're fine. And you were floundering, going, I have no clue what I'm doing. I hope I'm not doing anything wrong. And so, that is that role of assessment. Where's my supervisee at? Where can I help them grow? How do you limit your vulnerability, your liability, accountability, and responsibility in case of supervisee misconduct? That comes down to adequate quality supervision. That comes down into being well-versed in your state regulations, laws, your federal laws, HIPAA, 42 CFR, and being well-versed in your ethical codes of conduct. If you're multi-licensed, you're going to have multiple codes of conduct. Colorado, where I came from and I'm licensed, it's not uncommon to be an LPC, an LAC, an LPC, LMFT, LAC. And so you have 3 codes of conduct and 3 boards, all mental health laws, but then there are policies within each board that you have to know and be an expert on. And so that's the first and foremost, is being knowledgeable in those areas and being an active participant in your professional organizations. How do I respond to supervisee misconduct? That comes down to our role as a gatekeeper, our role as a clinical supervisor. By providing that supervision, appropriate, timely supervision, and ensuring that you are going through your client, your supervisee's cases, that limits your exposure. That limits the opportunity for misconduct. But people are people, and they will obfuscate or they will hide information. If you have done everything you have done, you generally may be okay. But when you become aware of supervisee misconduct, our ethical and legal obligation is to deal with them as the state or our professional organization deems necessary. So if it is a violation of a state law, reporting them to the board. If it is an ethical violation, it is reporting them to the ethical body. States often and ethical bodies allow for some level of leeway. So if it is a misstep, they didn't cite something correctly on a case note, is that to the level where they get grieved? Probably not. If they go out on a date with a client, yes, that has reached the level of a grievance. And so constantly monitoring and talking with your supervisees helps limit it and helps you respond to it. And so knowing the routes within your state, within your agency is important to know. And so I can tell you it is part of our gatekeeping function as educators is to make sure that our students are not operating impaired, mentally, any psychological, emotional, substance use, and making sure that they are operating ethically and legally. And as postgraduate licensure, it's operating the same way. And so ACA has a very nice ethical decision tree that helps you walk through that. But mostly what you're going to do is you're going to rely back onto your state laws on what you need to do. It can be anywhere from a grievance to an ethical report, or firing, up to firing either a intern, supervisee, or even removal from a program.
Dr. Rivas, would you mind ever so briefly talking about how our university supports our supervisors with trainees in that capacity?
Okay. So our current university, we kind of have we talk about high support, high expectations. So to have high expectations, you have to have high levels of support. And so anytime we place a supervisee at an internship site, the university and the department backs up the site with an internship class that's associated with the student being placed at the site. We go through a process of dispositions on every student. And as the student is progressing, by the time they get to internship, they are deemed, hopefully, to be an ethical legal practitioner as they're placed in the site. And with that, our support systems kick into place as an intern is placed. The site always has, they can reach out to the university. They're in contact with the internship or fieldwork professor or instructor. And if there is ever a question about what an intern is doing at the site, we support the decision of the site. And the first thing we ask is the site follow their own policies in place as they would with an employee, and to report back anything that the supervisee is doing on the site. And then if that's removing from a site, and then we would institute a remediation process on our end in order to ensure if the student is fired. If the student just has some difficulties, we can institute a support system on campus to make sure their skills are up to snuff and make sure that they are ethical and legal practitioners. I think that's where you were going with that. So we have about 10 minutes left. So I want to talk about the importance of having a theoretical model. Much like individual counseling or family counseling, having a theoretical model guides our clinical practice. And having a theoretical model for supervision guides how we're going to work with our supervisees. For instance, a cognitive behavioral supervision model is going to look very much like cognitive behavioral therapy. You're going to structure the supervision session in very much the way you would with a CBT session. There's going to be homework involved. There's going to be reviewing the homework that was presented from the last week. And there's going to be cases. And you're always going to be talking about cases regardless of what model you're coming from. You're always going to be talking about cases. It's just the lens that you're looking through and how you're structuring the session. And so by having that, that also allows a good fit. So as supervisors, you're going to be interviewing supervisees, unless your supervisees are assigned to you. And sometimes that does happen at agencies. You want to make sure you're you're interviewing your supervisee to make sure that you're a good fit for them and that they can learn the most from you. Just like when clients first come, you want to make sure that you can meet their needs. And the same thing goes when you have a supervisee. And that's where the theoretical model comes into place, is so you can explain to them how you conceptualize your supervision relationship and the direction the supervision will go.
Dr. Rivas, quick question in the chat. Can you spend some time on supervising via Zoom and any best practices?
Supervising via Zoom. Best practices are going to fall under best practice of teletherapy, right? One of the things that you really do have to be careful with Zoom is confidentiality. Virtual backgrounds, anybody could be in the background, and that has happened. Making sure that any of your, and Zoom is HIPAA compliant at this point, making sure any of your teletherapy sessions are HIPAA compliant, making sure that if you are transmitting electronic health records, that you are using encryption and not just sending them through regular Gmail, that you're using some form of electronic health record, or you're encrypting PDFs, something that would make it HIPAA compliant. Those are some of the main things that are that you want to ensure. The other parts is going to look very similar to teletherapy. Meeting your client, making sure they're in an area, or meeting your supervisee, making sure they're in an area where they can devote all their attention to the session, where they are not distracted, and setting aside time. Make sure you're setting aside time for them. I think those would be like the highlights briefly. I'm not sure if that answered the question.
Thank you. Aside from HIPAA, anything around building the supervisee working alliance?
Yes, the Supervisee Working Alliance via Zoom. As we all know, building any sort of alliance virtually is pretty difficult. And I would say, approach it as you do with therapy. Use a few of those sessions initially before the supervisee has a caseload for rapport building. understanding what the supervisee wants to get from supervision, understand what areas they need to grow from. And I have a nice little evaluation that I can send if anybody wants it, where you can give your supervisee before they even show up to their first session, where they outline kind of a learning plan, what they want to get from their hope to get from supervision, what they want to learn, what areas they think they need to grow in, what areas they're strong in, and spend some time working on that. Don't just get down and just, we need to work on this. Set aside some time to actually understand your supervisee as a human being and as a neophyte clinician. I would say that would be fundamentally, especially during this disconnected time. We do that naturally when we're in a room together, but via Zoom, we need to be more intentional in creating that relational piece. That would be my advice.
Thank you. And yes, that would be well appreciated if you could share.
Okay.
At some point.
So these are some of the supervision models. We look at it, and Bernard and Goodyear broke it down in roughly 6 areas. So models grounded in psychotherapy, developmental models, and process models. I have a tendency, I like the IDM, and I can share that with you in our last 5 minutes. It's ranked, and if anybody's familiar with ASAM and ASAM criteria, I like the IDM because it's broken down like ASAM. But there is no one right one. The right one is the one that resonates with you and that you can effectively do. And so we have psychotherapeutic models, developmental models, process models. We have combined models, where you take 2 models from the same category or 2 cross categories. We have target models that are very just focused. And then we have common factors models, which would be kind of an integrative approach. And so not one size fits all. Any questions on that? And we have 5 minutes.
There's one question I missed.
Sure.
How important is finding the right supervisor? And if so, how would you recommend looking for them as you are starting that relationship?
Very important. It's like finding the right counselor. And the way you find the right supervisor is you interview them. And this goes for supervisors as well. Interview your supervisees, interview your supervisor for good fit. And good fit doesn't always mean that you guys like the same sports team. That should never come into the equation. It is that you feel comfortable with this person. And that's that initial human reaction. Just like if you're looking for a therapist, you want to be able to sit in a room with somebody and be vulnerable with them. And that usually starts off in the first interaction where you sit with the therapist and you go, okay, this is a person I can talk to. So it's very important finding the right fit of the supervisor. I'm not saying if you're assigned a supervisor, it's going to be bad, but it's very important. And so look at that initial contact as both of you interviewing yourselves. And for future supervisors, it is definitely important that you interview your supervisees. That also helps you limit your liability. So this goes back to also the question was asked earlier is, assessing clinical readiness and impairment. So we use our clinical mind to look for impairment. We look for our clinical mind for clinical competence, whether the skills are there, the micro skills, whether they are able to provide, therapy in an ethical and legal manner. And, anecdotally, I'll tell you about, I had a supervisee a long time ago that in middle of groups started yelling at clients. That's problematic. It was an assigned supervisee. I was at an agency, didn't get a chance to interview them. And what we found out was after they started yelling at clients in group, pulled them aside, there were other things going on in their life that they were not dealing with. And so that supervisee was removed from the site and was put on a remediation plan. This was in a different state years ago. And they eventually, they came back and they did well. And then, I've had other supervisees that, they were at a point in their life where they said, I am I need more expertise in this. And so we worked on a referral process to get them to another area. And so that's what you're constantly looking at. Where does my supervisee need to grow? We need to let go of our ego and say, okay, where does our supervisee need to go? Can I give them more competence in this area, more skills in this area? And that's part of our role, is constantly looking at that. Ensuring legal practice, talked about that a minute ago. Direct observation, trust but verify. Sit in on your supervisee sessions. Make sure you are understanding what's going on in their sessions. And if a supervisee is not able to produce that material, have a conversation with them. Is it the client is refusing? And with direct observation, we do need release of information, but find out what's going on in there. Always make sure that you are participating in your supervisee's professional life. Provide verbal written feedback in a timely manner. Monitor and evaluate their clinical skills. Work with them. Do practice sessions with them. If they are light on a skill, walk them through how to do that skill. And encourage their skill development and growth, as I said previously. You don't want to just assume they have the skills. You want to monitor, you want to model it, you want to practice it, and then you also want to encourage them to go out and develop new skills through educational opportunities, continuing ed units, and ensuring that they are able to accomplish what they need to accomplish.
This may be related to your next one, but a question in the chat is, do you advise your supervisees be in counseling themselves?
Yes, I do, very much so. Physician, heal thyself. We need to be healthier than our clients. We, as clinicians, should be in therapy ourselves. Every therapist should have a therapist, and our supervisees should be in therapy. We, as therapists, are going to hear things that can cause vicarious trauma, and we need an outlet. We are a field where we hold the secrets, and we cannot just show up after a hard day at work and tell our roommates about our hard day. We cannot tell our spouses, our partners. We hold that information, and that is our honor and our sacred duty as counselors, is to hold that. And so the one outlet that we do have is our own personal therapy, so that we can have that conversation with somebody who understands what we are going through, and for us to work on what is coming up for us in our sessions. And that's good modeling behavior for our supervisees. One of the roles of a supervisor is to train the next generation to be better than us. And I really subscribe to that. It is kind of like a family system. Each generation should successively be more healthier than the last generation. And for our supervisees, we should look at that. They should be successively more healthier than us and better at counseling than we are. And as we hand the baton to the next generation of clinicians, hopefully they are better clinicians than we are.
As a follow-up to that, do you require your private pay supervisees to do counseling? Is it in your contract when taking on a new supervisee?
It is. Yes, I do. And that part is limiting liability due to countertransference. That is limiting liability due to boundary violations, and private pay supervision. When they are entering in that contract, they have an opportunity to say, no, I don't want to abide by this. I'll get supervised by somebody else, and that's their right. But for me, our supervisees should benefit from counseling, and I wholeheartedly believe in that. And that comes into this to gatekeeping. And I'll read you, SAMHSA right here, and talks about monitoring counseling performance is important and often difficult supervisory task, right? And if you notice that line there, individuals who should not be counselors. This field is a privilege. It's not a right. And unfortunately, some folks view it as a right versus a privilege. And so, we need to balance that. Is our job is not to go after people. It's to help people grow. But if they start to impact clients, then that other half of our responsibility comes into play. And KCREP speaks to that. ACA Code of Ethics speaks to that. It is important enough where it is a fundamental responsibility of supervisors that we are evaluating individuals' knowledge, skills, professional dispositions required by competent professional counselors and to remediate and prevent those that are lacking in those professional competence from becoming counselors. Gatekeeping and remediation from the ACA Code of Ethics speaks to that as well. And I'm seeing the chat light up.
Okay, so there's one, it's a little bit lengthy, but I'm going to read this one because there are two people interested in this as a question. As a clinical intern right now, applying for an EDD program, I know how difficult it can be to find clinical fieldwork, especially during the pandemic. What do you suggest for master's level students forced to engage with an agency lacking adequate supervision? I found myself educating and advocating for myself with regards to the supervision I receive.
Okay. So if there is inadequate supervision, i.e. KCREP requires 1 hour per week. States require less, and sometimes agencies will ignore the KCREP or the university's requirements. I would say if you are an intern, advocate with your fieldwork supervisor to move sites. If you are post-grad working on licensure, I would recommend having a conversation, or if they continue to not provide supervision, that you seek and you advocate for yourself and have that component where you would seek supervision outside of the agency, or even, and that is a possibility where you are seeking supervision from another supervisor. And that does happen with post-grad, where an individual may not be able to have supervision at their site, but they will contract with a supervisor who then works with the site to provide supervision, or change sites. And I know that comes from a place of privilege saying that, but supervision as a trainee is imperative. It is a must. And so that would be my recommendation. And as we start to run out of time, I want to just kind of hit a few points, and then I'll stay on for a minute to answer some questions. All of the Code of Ethics speak to an ethical responsibility in clinical supervision. And I just put up a few: ACA, MFT, NASW, APA, ASCA. They all speak to an obligation to provide clinical supervision, and that is our ethical duty. So the way we monitor our evaluator supervisee performance is we monitor, we give written feedback, verbal feedback every week. And that goes back to that question, is when you have weekly supervision, you're getting constant feedback and you're getting constant evaluation. And that's where you need to be during the learning process. Postgraduate, there's a little bit farther out how often you get supervision, but it's still designed to monitor and evaluate as soon as possible. It's like working in a job. If you only get evaluated in 6 months or your annual review, and you oftentimes look at it and go, well, I could have corrected that 6 months ago, 3 months ago, it doesn't help you looking backwards. It helps you in the moment. And that's where this guiding piece of evaluating supervisees' performance comes from, is doing it in the moment. And in the moment could be through direct observation when you're there with them, or at your weekly supervision meetings when you're reviewing tape, or you're going over transcripts, or they're even talking about their case conceptualization. Best practices: all supervisees have to have an informed consent with their clients to let them know. Colorado requires on a disclosure statement that they have the supervisor's information and license and education on the disclosure statement. Your supervisees need to disclose to their clients that they're under supervision. And that way, the clients can go into this with full acknowledgement. They also need to inform their clients that they're going to be sharing everything about the case with their supervisor. Contract with your supervisee, ensuring that you have all your roles and responsibilities outlined. This is especially important for private practice, private pay supervisors, that you do highlight what your responsibilities are for each of you, how you're going to handle any grievances, how you're going to handle terminating the relationship, what your fee structure is going to look like. Your expectations are outlined in the contract. What is your supervisee's role? What are they going to do for continuing ed, readings, etc. And establishing very strong boundaries with your supervisees. Remember what I said, it's an intimate relationship, it is not therapy. And sometimes those boundaries can be blurred. They need to understand that boundaries are there for their protection, the client's protection, and your protection. And it's also monitoring your supervisees for any boundary violations with their clients. Any questions? I buzzed through quite a bit, so I'm gonna stop share, and I'm gonna have the any
The
questions?
only one that we've missed in there is how what is the variance of private pay supervision in terms of cost?
It depends on where you are, where you're located, and that can range in price point from a reduced fee to low fee, all the way up to full practice. One of my former professors in Colorado was well sought after, and this was a while ago, and it was the other Dr. Rivas's professor as well. And he charged somewhere north of $300 an hour for post-grad supervision. And then other peers of mine have charged, I've known folks that charge as low as $5 in private pay. And so it really is your price point of where you live. Most of the time, if you work in an agency, you will have free supervision through your agency. And, I encourage most folks that work at agencies, to take advantage of that, because that really does help when you're going through this process, cost-wise. And I'm going to put in the chat the link for your CEs, and I'm going to send that off to you all. Any other questions or thoughts? Hopefully it was, albeit brief, hopefully this was informative for the participants. Please let me know if there's anything I can provide you. My email address, I will put it in the chat, is a.rivas@csus.edu. And I'll be more than happy if you're interested in those handouts or evaluations. I can share those with you. And all right.
Wonderful. Thank you so much.
Thank you.
Thank you, Dr. Rivas.
Thank you.